second. Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody. Sorry, I pushed a weird button. Okay, hello, everybody, and welcome to Airway Answers. I am super excited for today. I have the fabulous Dr. Louise O'Brien here with me. I'm not sure if you know who she is. I met Dr. O'Brien at the Sleep Education Consortium this year in Texas, and she presented the most fabulous presentation on sleep-disordered breathing and pregnancy. And it was just mind-blowing. Dr. O'Brien, it gives me the chills to even talk about this because I feel like this is sort of an unspoken topic. A lot of people are not aware of this link between pregnancy and sleep-disordered breathing and fetal outcomes. And I was a pregnant lady with sleep-disordered breathing that I was unaware of. I did not know I had gestational apnea in the form of upper airway resistance syndrome. And Dr. Simmons, years later, helped me identify I actually had moderate to severe sleep apnea, but little did I know. So when I was pregnant with my first son, for some reason, I had gestational diabetes. And I'm an athlete, I'm a runner, I'm not overweight. It just didn't seem to make sense. And I was the only female in the nutrition meetings because they make you attend weekly meetings with a nutritionist or a registered dietitian. I was the only sort of non-obese person there. It just seemed weird. I'm like, why do I have diabetes and we can't control this? And you have to write down every single food you ate all throughout the day. And back then it was a finger prick blood test. Maybe now they use a glucose monitor for this, but I had to prick my finger an hour after every meal, write everything down, meet with a dietitian every week, review everything I ate. And then I had to inject insulin in my stomach for the last few months of my pregnancy. And I chose the insulin injection versus the pill because I thought maybe that's more like human insulin. And it just was a very stressful time. And I remember when my blood sugar was high after eating, the nutritionist or the dietitian, whoever it was that reviewed everything with me, was like, well, what was the size of the pancake you ate? And they brought out a tub of plastic food items. And was it this size pancake or this, like to show me? It was very stressful, right? Which probably didn't help the issue because we know stress releases cortisol, which also increases insulin resistance, right? So then we found that I kept having to increase my insulin, which I know you're going to get into all this as we get farther along in pregnancy. We become more insulin resistant. And the weird thing was, but it's not weird now that I know what I know, but in the morning, my blood sugar wasn't controlled. I do all the protocols, but when I'd wake up, my blood sugar was always high for some quote unquote weird reason. Well, obviously I was running a race in my sleep, stressed out, having breathing issues, but we were unaware of this. And then my son was born with a series of issues that we've been struggling with throughout life with his own sleep disordered breathing and other issues. And I have sort of a little guilt, a feeling of, wow, maybe I caused this because I had undiagnosed apnea when I was pregnant, and my breathing issues must have had some impacts on the fetus and the growing child, so it's a stressful thing to be aware of. But had I been aware of this before I was pregnant or while I was pregnant, perhaps things could have been done a little bit differently. So this topic is just really interesting and important to me. And this is where, when I saw you present at the Sleep Education Consortium a few months ago, I thought, I've got to get this doctor on this show to help educate everybody. So I thank you so much for being here. And I'm going to go over your bio so everybody's aware of who you are. But again, Dr. O'Brien, I know you're busy, so thank you for your time today.
Thank you for the invitation.
So, Dr. O'Brien you are a lead sleep researcher and internationally recognized expert in sleep disordered breathing during pregnancy. Dr. O'Brien is associate professor in the Division of Sleep Medicine at the University.
This is where it's gone Ori, because this is out of date.
Oh, this is okay. So
Yeah.
actually, what we'll do is, and I'll clip that part out. So why don't you actually tell me your bio? So what I'll do is I'll say that you'll introduce yourself and talk about your background.
Okay.
Let me interject with one thing, and then I'll have you do that. So let's see. Okay. Have you done, it says you spent years researching the impact of sleep disorder breathing on snoring, obstructive sleep apnea. So let me do that, and then you'll talk about your background and history. Okay. Dr. O'Brien has spent years researching the impact of sleep disruption, snoring, and obstructive sleep apnea on maternal and fetal health. Her work has helped bring attention to the profound relationship between pregnancy, sleep, inflammation, cardiovascular risk, and long-term health outcomes for both mother and baby. At the Sleep Education Consortium meeting this year that I attended, Dr. O'Brien gave a fascinating presentation on pregnancy and sleep disordered breathing, which is a topic that's often overlooked despite growing evidence linking maternal sleep issues with complications such as gestational hypertension, preeclampsia, gestational diabetes, as we just talked about, fetal growth concerns, and adverse perinatal outcomes. And today, Dr. O'Brien is going to actually present to us on this topic. So this is just going to be an amazing sort of continuing education for all of us, reviewing a lot of information that she discussed at the Sleep Education Consortium and even more. So before we get started on your presentation, Dr. O'Brien, can you talk about your academic and educational and work background, so we all know where you work and where you're from?
Sure, yes. So thank you for the invitation. I'm very excited to be talking to everybody today. So I'm Louise O'Brien. I'm a physiologist by background. So I trained in the United Kingdom. I think you can probably tell the accent's a little different. And so I worked with a group that was interested in sudden infant death syndrome. So I kind of was in that maternal fetal space for a long time. And then because we were monitoring siblings of babies who had died of sudden infant death syndrome, I became very interested in sleep. Realized that sleep really wasn't a big thing back in the 1990s in the UK. So I moved to the US after my PhD, and then trained in pediatric sleep medicine, which was, fascinating. I still do work in pediatric cohorts as well. But it got me very interested to take that back to my maternal and sort of, the pregnancy health, because nobody was doing it at that time. And I came across an article from Australia, from Colin Sullivan, the man who basically developed the CPAP as we know it today, and was kind of, wow, why is nobody doing this in pregnancy? So that kind of started my, my journey. And I've been at the University of Michigan now for 20 years. And I'm a professor there in the Division of Sleep Medicine with a joint appointment in the Department of OBGYN. So this kind of marries the sleep and the obstetrics together.
Wow. Before you present, I do have a few questions for you on even more in depth how you got interested in this topic. So what made you realize that sleep disorder breathing during pregnancy needed more attention? Was it just because of that SIDS relationship that you saw working with the siblings of children who had passed away from SIDS?
Right. So that was where it started for me, because I really enjoyed working with the pregnant women and the newborns. And then once I was sort of learning more about what was happening during sleep of the newborns and the siblings of the babies who had passed away, I became very interested in, wait a minute, why is nobody looking at this in the moms? Right? Because surely something is going on, in the moms. What if they have this condition during pregnancy? And that's kind of what piqued my interest. So I'd say absolutely it was kind of starting off in that, maternal space. But I wasn't focused on maternal sleep at the time. It was more the sleep of the newborns, to try and figure out why things were going wrong for those babies who passed away from SIDS.
Yes. Did you find in the siblings of the babies who passed away from SIDS, there was any, and maybe this is something you're going to talk about in your presentation, but any correlation between sleep disordered breathing type issues or maybe craniofacial anomalies in the siblings?
We weren't actually looking at that. We were looking more at kind of oxygen levels and breathing patterns. But for sure, we know now, I mean, we're sort of 25, 30 years down the line now. But we do know now that there's a genetic component. So I think that speaks to, a lot of the work that's going on now. But it's not one condition, right? There's a lot of things that factor into, what, like if you're talking about SIDS, there's a lot of things that factor into that autonomic nervous system. I mean, genes now, it's very, very complex.
Okay.
And thankfully the numbers are reducing, but it still happens, unfortunately.
I am very fascinated with SIDS, and I don't know so much about it. So it is a genetic disorder. There's a
No, I
genetic
was talking about genetics for the sleep apnea.
for the sleep apnea.
Yeah.
Okay, can you talk
Yeah.
a little bit about SIDS? What are some of the factors that are playing a role in that? Do we know what causes that? Is there a genetic relationship?
So I'm kind of out of the literature of that. I haven't done that for a long time. But we do know that, autonomic nervous system can play a role. There might be some genes. We also know common things like, it being in a smoking environment. So parents who smoke or, I think the sleep position has been known for a long time, for decades now, about, it's important to lie babies on their back. And not in the prone position, not on their tummy, overheating, not being on the right sleep surface. So I think, a proportion of SIDS cases that happen now are often found, in the parent's bed or in an armchair. Somebody's fallen asleep with the baby on their lap. Maybe the baby's overheated or has become trapped somewhere. So there's lots of, there's lots of potential reasons that can play into
Okay.
SIDS.
And do we know, is there a relationship between SIDS and sleep disordered breathing, or children with apnea are higher risk for SIDS?
That's a great question, and I haven't looked at that literature recently, but there was certainly some interest, in that area.
Okay.
I'm
always
kind of
curious.
out of the SIDS literature, honestly. I haven't looked at that in decades, so
Okay.
I don't know that I'm telling you the right information.
No
right
problem.
now.
No problem. We can clip stuff out. And we can also see if this is okay or not okay to say. But I'm curious, the back to sleep protocol for children with sleep disordered breathing or at a higher risk because perhaps they have narrow palate, retruded mandible, laying flat on their back can actually make it more difficult for them to breathe. But we know that's the protocol, is back to sleep to reduce the incidence of SIDS. And I remember I was torn about this as a new mother because my baby would jolt and couldn't breathe a while when he laid flat on his back. So I had to prop him almost sitting up, almost in like a car seat to sleep because of the reflux and the issues with like tongue tie and that whole aspect. And sometimes these babies, and this is not a recommendation for anybody, this is my experience, is not prescriptive medicine or anything. I'm just stating that I noticed my baby would sometimes sleep better if he was either propped up very high, but on his back, or on his belly. It would help him fall asleep and stay asleep better. And although that's not the recommendation, it's just an interesting thing when there's probably subgroups of children with SIDS, and some might be maybe airway craniofacial related, and some might be smoking related and heat related, or other factors. And I bet if they did have this compartmentalized, there might be different recommendations, but
Right.
just an interesting observation.
Yeah, that's a great point. I think, recommendations come out as sort of blanket recommendations for everybody. And clearly not everybody fits those categories, right? There are subgroups. So I think you make a very valid point.
When I was diagnosed with gestational diabetes and we just thought, oh, it's genetic. I went through that whole phase and then later learned that I had sleep disordered breathing of a pretty significant degree, although I'm not a mouth breather, didn't really snore, but I had significant sleep fragmentations from upper airway resistance syndrome. So I went back and told my OBGYN about this a couple of years later, and it didn't really seem to matter or spark curiosity or interest. So I'm wondering, why do you think sleep and sleep disordered breathing is so maybe under discussed in obstetrics?
That's another great point. I mean, I think primarily clinicians don't get the education, right? In medical school or nursing school, it's very, very limited. And I think it's just not really that well known, unfortunately. And I think that's part of our job, being in this kind of sleep research and sleep medicine space, is to educate people, because, honestly, if you have poor sleep, it affects every other part of your life, as I'm sure you're aware. It can be your mood, it could be your quality of life, it could be hypertension, diabetes, the things that you've mentioned. It really does affect nearly every other aspect of medicine. And that's why it's really fascinating to me as a researcher, to be able to, work with these populations. But I think the other side of it is that when you go, let's say, for example, to an obstetric appointment, it's a busy time, right? The obstetrician has a lot of things that they want to get through. For your gestation diabetes, as an example, sleep will not really be on that list of topics. And I think, again, this is our job to make sure that sleep can get into obstetrics as a routine sort of screening. It takes a minute to ask about somebody's sleep. And I'm not saying that obstetricians can necessarily be then, dealing with it and treating it and all of that, but at least you're aware and can potentially refer on to somebody that can, treat if it is obstructive sleep apnea, diagnose and treat.
Yeah, it's so important for every age, whether we're talking about obstetrics, whether we're talking about pediatrics,
Mm-hmm.
general medicine doctors, cardiologists, everybody to have questions about sleep on their questionnaire
Yes.
and write their intake forms, their check-ins, checkup appointments, but not just ask, but also investigate further because it does impact every aspect of our health. Every single cell in the body can become impacted when we're not breathing well during sleep or not sleeping well. So I think this is a perfect segue for you to do your presentation for us. So if you
Okay.
want to get your screen started, we can share that. And I do have tons of questions, but I'm sure they'll mostly be answered when you present. But after, we can go over some more questions about this topic.
Okay. Can you see? Let me see. Share screen. Let me know when you can see it.
Okay. I can see your screen, but yeah, you can go ahead and put in presentation mode. Perfect. All right. Well, thank you so much. Here is your presentation. So we're ready for it.
All right, well, thank you. So I'm going to give a brief overview of sleep disturbances in pregnancy and what are the implications for maternal and fetal well-being. So there's my conflict of interest slide. So let's start with the healthcare burden of obstetric conditions. So if you can see, these are the top conditions that obstetricians see. So hypertensive disorders like gestation hypertension, preeclampsia, gestational diabetes that we've briefly touched on, depression, preterm birth, pregnancy loss, and stillbirth. And you can see that all of these are, not infrequent in this country, and they actually carry not only a huge psychological burden, but also a large, financial burden as well. So if you just keep this slide in mind, because we're going to circle back to it at the end. And I think it's important to point out that all of these conditions are approximately double in minority women. So that's a big burden to women themselves and to the healthcare system. So you're probably thinking, what on earth does maternal sleep have to do with these big obstetric conditions? And I would argue that sleep has everything to do with it. So you can see the sort of 3 pillars of health up there. We have nutrition, exercise, which everybody's familiar with, but also I think sleep is really our 3rd pillar of health. And, this is a very ubiquitous, it's a physiological phenomenon. It has a huge impact on our basic physiological processes. So, for example, things like your metabolism, your immune system, your hormonal system, as well as things like behavior, cognition, emotion. And when you think about it, we spend about 1/3 of our lives asleep. And so what happens during that 1/3 really impacts the other 2/3 while we're awake. So what about the frequency of sleep issues and problems in pregnancy? Well, I can tell you that it's really common. So you can see from this slide here that things like insomnia and poor sleep quality really impact the majority of women, somewhere between 65 and 75% of women. And I think that is actually part of the problem when you may go to an obstetric visit and, even if they ask about sleep, you say, oh, I'm not sleeping well, I can't sleep. It's like, oh, well, this is just part of being pregnant. And those symptoms overlap, and part of it is part of being pregnant, but there is some of it which is clearly not okay and really, warrants treatment. So SDB is sleep disordered breathing. We're going to talk more about that for much of this talk, actually. But as you can see here, it affects about a third of women, especially about the third trimester. So that's important. And extreme sleep duration, restless legs. When I talk about extreme sleep duration, I mean maybe less than 6 hours or more than 9 or so hours. Restless leg, very common in pregnancy. We're not going to talk about that today, but it is very common. And then supine sleep position, which we will touch on a little bit in these slides. So I think just suffice to say that, sleep problems are really common during pregnancy. Now, all of these different kind of sleep metrics, if you like, whether it's sleep disordered breathing and sleep apnea, whether it's poor sleep quality, insufficient sleep, sleep timing, even when you time your sleep is important, or your sleep position, all of these things feed into poor pregnancy outcomes. And each one of these could actually be a talk in itself, but I'll try and touch on most of them. So the big one where most of the research lies is in sleep disordered breathing. So sleep disordered breathing is like an umbrella term that covers habitual snoring at one end of the spectrum all the way through to obstructive sleep apnea at the other end. So in terms of habitual snoring, people often make jokes and comment like, oh, you sound just like your grandfather or something like that. But actually we should be taking this seriously. Habitual snoring affects about a third of women by the end of pregnancy, and up to 85% of those with preeclampsia. And again, we're going to talk about that a little more. But this figure here basically shows the frequency of habitual snoring, and habitual, I mean like about, more than 3 or more nights a week. In early pregnancy, you can see it kind of increases in the third trimester, and then postpartum, it comes down again, although the literature is a little limited in the postpartum period. But I think it's pretty clear that it doesn't matter which study you look at, this will peak in the third trimester. And what we're learning is that, more than half of women, almost 2/3 of women who have these symptoms during pregnancy still have persistent symptoms once they've delivered their baby. And it really is an unknown at this point in time when or if sleep disordered breathing resolves. And if you think it's also linked to excess weight, right? And how many of us, snap back into being nice and slim when we've had babies, not too many. And then we may get pregnant again, especially if the interval is small between children, then, how many women still have unrecognized sleep disordered breathing when they then go on to the next pregnancy? So these are all sort of, open questions at this point. So before we talk about sleep apnea, I just want to, make sure that everybody's aware of, we're all on the same page. So we see the airway here. We can see the blue lines are sort of the air going through the nose and the throat there. And then when you have the sleep apnea, we have this blocked airway, and we can't get our air through down into the lungs. And this is a sort of a 2-minute screenshot of an overnight in-laboratory sleep study. So what we're looking at here, the black lines sort of on the top half are the EEG, so the brain waves. And then what I want you to focus on is more the second half, the bottom half of this figure, where you can see these sort of flat lines here that are highlighted in purple. So this is airflow coming from under the nose. And then the next 2 lines, we've got chest wall movement, we've got abdominal wall movement, and at the bottom in the red, we have oxygenation. So what you're seeing here is that there's a blockage somewhere, right? Because we have a flat line, so there's nothing coming out of the nose, the airflow is flat, yet the chest and the abdominal wall are still moving, right? So this is telling us that there is a blockage, because that chest and abdomen is still trying to move air, but nothing is moving out of the nose. And you can see that we've got some oxygen desaturations dropping down into the 70% mark down here. So they're highlighted in pink. And then, somebody wakes up, they gasp for air. We see these arousals on the brain waves, the EEGs here. and then they go back off to sleep, and the whole cycle starts again on the next page. So just to orient everybody, the apnea-hypopnea index, so apnea is just complete blockage, the hypopnea is a partial blockage of the airway. If we add all of these up and divide by the number of hours of sleep, we get a number. That number is called the AHI. If it's less than 5 in adults, it's pretty normal. 5 to 15 would be like mild sleep apnea, 15 to 30 moderate sleep apnea, and above 30 is severe sleep apnea. So that just gives us an orientation of what we mean when we talk about sleep apnea or severe sleep apnea. And we will touch on this later on. So in terms of sleep apnea, meaning diagnosed by an overnight sleep study, not a whole lot of literature. It's certainly coming out more now in the last sort of 5 to 10 years. But what we know so far is that by mid to late pregnancy, obstructive sleep apnea affects about 8 to 10% of pregnant women. And then if you're obese with a BMI of 30 or more, it's about 15 to 25%. Some work that we've done here in Michigan, we've looked at women with a BMI over 40. Again, we've seen that's over half, so about 60% of women have obstructive sleep apnea, and 50% of women with preeclampsia have unrecognized sleep apnea, right? So you think about, how many patients go and are, on meds for preeclampsia, but how many of the obstetricians are asking those patients about their sleep? My guess is probably not very many. And of course, we talk about the obesity, right? So it's been very clear that, the more obese you get, the class 1, class 2, class 3, once you get sort of up there into class 2, then, the odds of sleep apnea are considerably increased, as you can see from that figure. So when somebody has sleep apnea, what happens? So here we're looking at oxygen on the top, flow. And then this is an esophageal pressure, and we'll talk about that. Then blood pressure, and then sympathetic nerve activity. So really, this is sort of the mechanism of how sleep apnea is linked to high blood pressure. So we have an apnea, okay? So we've got nothing going on with the flow here, right? Somebody's having an apnea. So the oxygen level will drop, right? We see this oxygen drop here. At the same time, when there's this apnea going on, this esophageal pressure, this is measuring the work of breathing. You see how this gets more and more negative? So that person's trying to breathe against a closed airway, right? And like we said, the saturation goes down, but then the blood pressure is going up a little bit, just a tiny little bit. But you see at the end of every apnea, here's the apneas at the top, the second one down. At the end of every apnea, there's a little blip in blood pressure, little blip in blood pressure. And you can see that matches this increase in sympathetic nerve activity. So you can imagine if this is going on, multiple times an hour every night, you can see how this is the mechanism for ultimately the blood pressure during the day will get higher and higher. So we can also, instead of what I've just discussed, which is looking at, women with sleep disordered breathing or obstructive sleep apnea, and the hypertension, we can also flip that around and say, okay, well, how many women with hypertension have obstructive sleep apnea, right? So we've done that. There's a couple of places have done this now, and we showed quite some time ago now that if we took a group of pregnant women with hypertension, and we didn't know what their sleep status was. I mean, we did find out afterwards, but we didn't ask them in the beginning. We just enrolled them because they had hypertension. This is what we found. So we gave them sleep studies. We went back and we looked at the sleep studies, and we found a huge range of this apnea-hypopnea index that we've just talked about. And the average was 13.5. And you think that sleep apnea is really like an AHI of 5 or more. So many of these women had sleep apnea, and you can see that highest one was 117 times per hour that lady was stopping breathing. And so you can see from these figures here, these numbers, that, almost half had sleep apnea, but 12% had severe sleep apnea. And none of these women had taken these concerns to their doctors, and none of their doctors had asked during sort of the regular OB visits. And so if we put this in a table with, hypertensive women who snored versus those that didn't snore, what we found was that in those who didn't snore, the ones that had sleep apnea, that was just mild. But in those who had hypertension and they reported snoring frequently, look at that, half of them had sleep apnea, and kind of scarily, 20% had severe sleep apnea. Okay, and so when we did the analysis for this, what we found was that the relative risk for having sleep apnea, if you're a hypertensive woman who snores versus non-snoring, was double. Okay, so that should be a red flag, going forward to obstetric clinicians, that if they do have a hypertensive woman, you ask her if she snores, that should be a red flag to investigate for sleep apnea. So if we look back at the literature now, because there's a number of studies that have been done looking at sleep disordered breathing and hypertension, what we find when we pool all of those studies, and there's more now, but the findings are still the same. If we pool all of those studies, women have double the odds of a hypertensive disorder if they have snoring or if they're diagnosed with sleep apnea. The results are the same whether it was just the symptoms or a diagnosis. It was double the odds of hypertensive disorder. But it's not just that you want to ask the woman when she comes in for care if she snores. I think it's really important to ask the question again and again, right, as she comes back as the pregnancy progresses, because new symptoms can very easily occur as the pregnancy progresses, because you're gaining weight, you've got more fluid retention, more rhinitis, things like that. And so that's one of the things that I was very interested in when we started some studies at the University of Michigan quite some time ago. And what we did find was that when we looked at, when these symptoms had begun, was it before pregnancy? Was it during pregnancy? We found here that if it was pregnancy onset, so these sleep disorder breathing symptoms started because somebody was pregnant, we can see here on the far right that it was that group that was really driving that relationship with the high blood pressure. So maybe it's because, the body gets sort of this insult, if you like, during pregnancy and doesn't have time to adapt. And so the result is increased blood pressure. That's sort of the thought at the moment. It's not just high blood pressure, it's also gestational diabetes. So again, if you pool all of those studies, and with the studies that have been published more recently, it's probably a 2 to even 3 times odds of gestational diabetes in women who have sleep disordered breathing during pregnancy. So it's a pretty high high risk of that. And when you think about the sort of the cycle of gestational diabetes, if you have gestational diabetes, you can, the babies can end up, sort of with epigenetic predisposition to maybe obesity, maybe having diabetes themselves in adulthood. And if the baby is a female, then you think about PMOS. It's not PCOS anymore. We have a new name. It's polymetabolic or polyendocrine metabolic ovarian syndrome now. I think that name came out a few weeks ago. And then, women who have that then have trouble getting pregnant themselves and then potentially starting the cycle again. So I think it's really important that we can intervene soon to sort of prevent this, this vicious cycle. And I think sleep is potentially one way to do that. But it's not all about obstructive sleep apnea. It's also sleep duration, right? So this study done some time ago now looked at blood pressure and different durations of sleep. So the ones that I want you to focus on are sort of the red bars and the green bars, because that's the extremes of sleep duration, less than 6 and more than 10 hours. And then we're just looking at blood pressure in the first, second, and third trimester. So I think what's pretty clear from here is that once you get to the third trimester, things start to change. And you start to see this kind of U shape, right, where the extremes of sleep duration have the highest blood pressures. And so why is that important? Well, shorter sleep duration is also associated with higher uterine artery resistance. And we know that higher uterine artery resistance is linked with preeclampsia and fetal growth restriction. And it also more than doubles the odds of hypertension years after delivery. So this isn't just a problem for the pregnant woman and the fetus right now. This also has implications downstream, potentially decades later. Similarly, for gestational diabetes, sleep duration is very important. It has this U-shaped curve. particularly strong for those who sleep less than 4 or 5 hours per night. We see in one of the studies it showed a risk for gestational diabetes of 5.5 times in those who were sleeping less than 4 hours a night. So, not getting good sleep is not a flex. Or I think a lot of people think that it's kind of a cool sort of flex thing to do. Oh, I can, I'll sleep when I've got time. Well, no, actually, you need to prioritize your sleep, particularly when you're pregnant, because you're sleeping for two, right? Your sleep can impact your baby. Short sleep duration has also been shown to be inversely related to the oral glucose tolerance test. So for each hour of reduced sleep, it's been shown to be linked with a 4% increase in glucose levels in pregnancy. And that's just sleep duration. That's not even sleep apnea on the top. So you can imagine if you have short sleep duration and you have sleep apnea, that potentially could be even more elevated. So we talk about duration. I think we all have heard about, 7 to 8 hours. That's what you need, but you have to time it right. Sleep timing is really important. And this is something that we're starting to learn over the last, I'd say decade now. There's literature in the non-pregnant population. There's very little in the pregnant population, although it's starting to come. So I think that's going to be an area that people are publishing on and moving the needle forward quite a lot. So when we think about sleep timing, we think about the midpoint of sleep. Where is your midpoint of sleep? So the midpoint of sleep is halfway between when you go to sleep and when you wake up. It's really that simple. And it's really a marker of your circadian alignment, right? So is your body in alignment with sort of the light-dark cycles? Right? And the normal midpoint is between about 2 a.m. and 4 a.m. And what you're looking at on the screen is a snippet about a week's worth of actigraphy data. So an actigraph is like a medical grade, I guess like a Fitbit, right? But it's a medical, it's approved for medical use, unlike the Fitbits, which, are great, but they're not really developed for what we're looking at here. And so what you see is each row is a 24-hour period. So I think it starts up here on a Wednesday, then Thursday, Friday, and so forth. The yellow that you see is light, because these actigraphs, if you look at the bottom left picture, you see that little circle in the picture, that's a light sensor. And so it picks up light, so it can kind of figure out if you're out in bright light or you're sort of in a dark room. The black is activity. So if you're walking, running, just, exercising or just, walking and doing, walking around, being active, basically. And then the blue is sleep. So I've highlighted that in blue so you can see, but underneath that blue, you can see that everything kind of drops away. And so I think what you see quite easily with these actigraphs, if you get a good sense of sort of rhythms, right? And you can see here, almost without even looking at that left column, I can tell that this is the weekend because it's, Friday, nobody's going to bed till later, they're getting up later, and the same on sort of Saturday into Sunday, right? So this is a good visual of what's going on. And so if we look, we see that those midpoints, they shifted to the right there at the weekend, right? They're not kind of as stable as might be good. And so what we're learning is that these delayed midpoints, these later midpoints that are shifted to the right of that figure, are related to an increase in gestational diabetes, an increase in preterm birth, an increase in depressive symptoms. And what's really important is that even if your sleep duration is 7 to 8 hours a night, if your midpoint is delayed and you have circadian misalignment, we still see all of these increases, right? So timing is important. Okay, so there is a disproportionate burden of sleep disturbances in Black women. I think we know from literature outside of pregnancy that this is also the case. We know that there are higher prevalence of sleep disturbances and quite often a greater severity in Black individuals. And what we believe is that might contribute to the greater cardiovascular morbidity seen in the Black population. So in terms of pregnancy, we've done studies in Detroit where we've looked at Black pregnant women compared to white pregnant women in terms of their sleep. And we found that in the Black women, there's a higher prevalence of short sleep, worse sleep quality, more insomnia symptoms, more symptoms of sleep disordered breathing, meaning sort of pauses in breathing or gasping for air. And then when we kind of looked at those together, we were really surprised by the number of sleep-wake disturbances that a given woman can have. And this was in the Black women, and as you can see here in this graph, about 20%, 25%, 23% of women were having 4, 5, and 6 sleep disturbances all at the same time. So this is really burdensome. And you think about the potential impact of those disturbances on not only the mother, but also the offspring. So we've also done studies in about 175 women where we've given them home sleep apnea testing. And we've been able to go back to them. Like, we've gone in early pregnancy around 15 weeks, and we've gone back again in late pregnancy to see how things change across pregnancy, right? Because nothing stays the same. It's a dynamic state. And so this figure is showing white women in the blue colors and black women in the pink colors. The lighter shades of each color are early pregnancy, the darker shades are late pregnancy. And I think what we see here is that sleep duration is universally low. It seems to get a little better as pregnancy progresses in the black women. If we look at the apnea-hypopnea index, the severity of sleep apnea, what we see is that it gets worse in both groups of women as pregnancy progresses, but it gets significantly worse in the black women. And that's also reflected in the oxygen desaturation index, which is the ODI. We see that increasing in both groups, but really increasing in the black women. And then in terms of the sleep position, we're going to talk about this later on in the talk, but we were interested in the proportion of women who were sleeping on their back during pregnancy, and we were really surprised to find out that it was a lot more than we thought. You can see here that in early pregnancy, it's about 15-16% of white women spent time in the supine position compared to about 23% of black women. But as pregnancy progresses, both groups spent more time on their back, which was a surprise to us. We thought it would be less time. But again, in the black women, it was significantly more. So the takeaway from this is that not only do black pregnant women have poorer sleep than white, sleep appears to get even worse as pregnancy progresses. And that makes you wonder if these changes actually play a role in the worst perinatal outcomes that we see in black women. And if that's true, then we have, something to intervene, right? So what about the fetal impact of maternal sleep disruption? Okay, so fetal size is really important because we know that fetal growth restriction, whether that be and small for gestational age or large for gestational age, all of these have increased risk of perinatal morbidity and mortality. So there's been lots of studies done in this area. You can think about the immediate consequences of fetal growth restriction, which are things like preterm birth or even stillbirth. But we also know that this kind of falls into the fetal programming, right? And babies who were born very small have an increased risk for cardiovascular disease decades later. So those studies were sort of done, from the World War II, actually, and followed those babies up for decades and decades and found that, they had much higher risk for cardiovascular disease. So this is an important a very important area to think about. And so how does that play into maternal sleep? Well, we did a study about this back from, maybe 10, 12 years ago now. And we looked at the birth centile outcomes. But again, because I was interested in the timing, and we talked about this with the mothers and the hypertension, we went back and we looked at how onset of these symptoms impacted the delivery outcomes. And what we found was that this time it was the women who had the chronic symptoms of sleep disordered breathing. Basically, they had them before pregnancy, so they entered pregnancy with these symptoms and they had them during pregnancy. Those women were the ones that had the smaller babies. Right? If we just asked a simple question, when the babies were born, hey, did you snore in pregnancy? Basically, these two groups, the pregnancy onset and the chronic snoring, would be sort of lumped together and combined. That effect would be washed out. But because we were interested in the timing of these symptoms, we were able to look at those separately. And we clearly saw that those babies that were smaller were actually born to the women with the chronic symptoms, which is the opposite of what happened to the women with the hypertension, remember, because they were the pregnancy onset symptoms were the ones that were driving the hypertension. So the way I think about this is that maybe if women enter pregnancy with those symptoms already, that little embryo just really doesn't get a good start in life. and maybe just, cannot reach its potential. That's just a, hypothesis. Nobody's really tested that yet. That's an area rife for, investigation. And so this has also been repeated by another group in Canada. They did it with, objective measures with the sleep testing. And what they found was, as the severity of sleep apnea got worse, the proportion of small babies also increased. Okay, so this has come out of several studies now. And then if you pool all the data that we have, whether that be just symptom-based or objective measurement, again, we find the same thing, is that women who have sleep disordered breathing, whether that's just the snoring or whether that's a diagnosis of sleep apnea, they're about 1.5 times more likely to give birth to smaller babies. So it's not just about the birth size though, right? Because if you think about pediatrics and you go and you take your child to well visits with a pediatrician, you have a growth curve, and they follow the growth of the child. And if the growth starts to tail off, that's when we can look a bit closer and see what's going on. Well, you can actually do this with a fetus, although it's only really done for babies who have problems. It's not done routinely, but we have done it routinely for research purposes. So women that wouldn't normally have fetal ultrasounds after their initial growth scan, we have done this. So this one I want to show you first is a study that came out of Australia. So if you think about a fetal growth curve, it looks very like a pediatric growth curve, except you do it through ultrasound. The blue line on the 50th centile line there is the appropriate growth, right? So average growth, it follows the centile as the pregnancy progresses. The pink one is a small for gestational age baby, so it's tracking the centile. It's just small. Maybe the parents are small, and so those ones are typically fine. It's the red one that we're kind of concerned about. This is a growth restricted baby, so it was tracking its centiles nicely until a certain point in time, and you can see that it now falls across those centile lines. Okay, so that would be a growth restricted baby. Now that baby could technically be born at, maybe 6 pounds something and may not raise too many eyebrows. But if that baby was being tracked during pregnancy, maybe that baby was supposed to be a 9-pound baby, right? So this is an important consideration. So anyway, this study that came out of Australia had 14 women with a diagnosis of sleep apnea and 27 without. And if you look at the birth weight less than the 10th centile, so if they just measured the baby when it was born, there was no differences between their birth centiles, okay? But if they looked at a growth, an ultrasound measure at 32 weeks, and then the birth centile, and drew a line between the two, and looked to see who was falling across the centiles, right? Then the babies born to the women with sleep apnea were much more likely to fall across the centiles, right? So that is missed. If you're only taking a birth centile, you miss this whole trajectory and babies falling across the centiles. Okay, so that's telling us that something's happening in the women with sleep apnea and their babies aren't growing optimally. So I'm going to come back to that later on, because we've done a study kind of to build on that one with some really interesting results. But before I do that, another thing that we were interested in are looking at the timing between maternal respiratory events and fetal heart rate. Okay, so there was a home device that we got. There's a picture at the bottom there. It's basically a home fetal monitor. And what we did was we got this home fetal monitor and we did a home sleep study on women at the same time, because I was very interested in what are these babies doing when the mom is asleep. Like, we really don't know, okay? And so there's a picture in the top right. So the blue line is the baby's heart rate. So this is the fetal heart rate. The red is the maternal heart rate, and then the black is kind of uterine activity. And so we were able to time sync the sleep studies with this fetal heart rate device. And just as the image there, we had like a maternal apnea happened around here, and you can see that the baby's heart rate drops. Okay, that's just a visual of what I'm going to tell you. But we had this study about 41 women in the 3rd trimester. About half of them had sleep apnea because we'd done the home sleep apnea test. And when we went back to look at the data, so I just want to first of all say that we did not look at any data until these babies had been delivered, because we didn't know what we were going to find, and we didn't know, if what we found, how could we, change clinical care, because we don't really know what's going on at night anyway. So we decided not to look at any of this until the babies were born. So we didn't sort of interfere with their clinical course. And so when the babies were delivered, we found that 18 women had late deceleration. So a late fetal heart rate deceleration is basically, it can be a sign of fetal distress. It can be caused by hypoxia, which we see in obstructive sleep apnea. And because these two devices were time synced, we could tell that the vast majority of these fetal heart rate decelerations were within 30 seconds of a maternal apnea. Okay. And then we saw 10 prolonged fetal heart rate decelerations, and these happened in 6 women. So that means that not only did the baby's heart rate go down, it stayed down for quite some time, on average about 4.7 minutes, which is, a fair amount of time. And these prolonged decelerations can lead to a clinical intervention. So when do you see these? So when women are in labor and they're being monitored with a fetal heart rate monitor, if these prolonged decelerations are seen, this is often a time when the baby will be delivered, right? There'll be an intervention, baby will be delivered. But of course, we're doing this in the 3rd trimester. Women are not in labor. We're doing it at home. What does this mean? And truly, we don't know. But when we went back to look at the sleep studies of these women, these 6 women who had these really long fetal heart rate decelerations, all of them had sleep apnea, and all of them had unrecognized sleep apnea. So none of their physicians knew that they had sleep apnea. And the vast majority of these fetal heart rate decelerations were linked within 30 seconds to a maternal respiratory event. So again, this is telling us, when that mom is having an apnea, something is happening to the fetus, right? The fetus is having some kind of response. So this, again, there's not much out there in the literature. I think this is a field that we could focus on. So some studies also show an increased odds of excessive fetal growth. So this is a large population-based study. So this is all either symptom-based, or it's a diagnosis, like a hospital discharge diagnosis. But remember that the vast majority of women, maybe 90%, don't know that they have this. So it won't be a diagnosis in their medical records because nobody's ever tested them. So I think we just have to keep that caveat in our mind. But nonetheless, there are studies out there which will show that maybe these symptoms or diagnoses are linked with large for gestational age babies. Or maybe an increase in the birth centile. So again, this is a complex relationship, because if you think about what's going on when you have sleep apnea, you can have sort of the metabolic dysregulation going on, which might promote the large babies, or you could have the vasoconstriction and the high blood pressure in the mother, which can promote the smaller babies. So it's certainly not an easy answer. Okay, so what about shift work? So shift work is kind of a circadian misalignment, right? And what we know in non-pregnant women is that if you're a shift worker, you do have changes in your reproductive system, right? So you have changes in your menstrual cycle length, you might have irregular cycles, you might have increased risk of endometriosis, you might not have as many oocytes as somebody that doesn't work shifts. I mean, so there's a change in your reproductive health, right? We also know that working shifts suppresses your melatonin. You get this hormone imbalance. It increases cortisol, your stress hormone, and it's also a long-term cancer risk. So we know from a lot of data that working shifts can increase your risk of cancer, and that's in males as well as females. So what about if you're pregnant and you work shifts? So the literature so far shows that there's an increased risk in pregnancy loss. In fact, there's even an increased risk in getting pregnant in the first place. There's also an increased risk of preterm birth and smaller babies. And literature shows that women who work 2 or more night shifts in the prior week to, filling out questionnaires had a 32% increased risk for miscarriage. And that miscarriage risk sort of increased as the number of night shifts increased. And then a big meta-analysis of over 1 million women showed that there was a 63% increase in preterm birth in women who work shifts. So this again gets to this circadian misalignment, right? And making sure our sleep times are aligned with what our body's rhythms are. And because we know that, keeping that regular light dark cycle and sleep wake cycle is really important to optimize your circadian rhythms. And why is that important? Well, if you're carrying a baby, then it's likely that somehow, that we don't fully understand yet, that your circadian rhythms are somehow priming or imprinting on the fetal circadian rhythms. And so therefore, it's very possible that what we call chronodisruption can have a negative impact on that developing fetus. And I think, again, this work is all sort of very new, and there's a lot to learn in this field, but it's very exciting. Okay, so I'm going to shift gears a little bit now and talk about stillbirth. So stillbirth is the death or the loss of a baby before or during delivery. So in the US, it's the loss of a baby after 20 completed weeks of pregnancy. And we have early stillbirth and late stillbirth. So the late stillbirth, so I'm going to focus on for the next few slides, and that occurs after 28 completed weeks of pregnancy. So you're probably thinking, isn't this a rare event? We don't hear about this. And I will argue, no, this is not a rare event at all. The stillbirth rate in this country is about 6 per 1,000 babies. So that makes about 24,000 babies every year. And approximately half of these are late stillbirths, right? So these are third trimester stillbirths. These are babies that potentially, if we'd known that they were a vulnerable fetus, for instance, could we have intervened? Because, at 28 weeks, there's a good chance of doing well after delivery. It's 10 times more common than SIDS. We talked about SIDS a little earlier, and yet I think nearly every hospital, when you take a baby home, they will talk to you about the risk for sudden infant death syndrome. And yet stillbirth is 10 times more common than SIDS, and I don't think there's enough talked about for risks of stillbirth. It is equivalent to a 747 crashing every 5 days for a year. And I think if that was happening, the FAA would have something to say about it, but still, we don't talk about stillbirth. So why is sleep important in stillbirth? So over the last decade or so, several case control studies and one cross-section study all demonstrated a link between maternal self-report of supine sleep and late stillbirth. So it started out in New Zealand, and then there was a study in Australia, there was a study in the UK. We did a study in Ghana, and that was the cross-sectional study, and we all found the same thing. I mean, that's almost every continent in the world, all pointing in the same direction. So there's something going on between maternal supine sleep and stillbirth. Now, just bear in mind, these are all self-report of sleep position, right? So what we've done is we've gone back and we've pooled all of these studies together, right, and looked at them as like one big study. And so when we pool all together, we had 851 late stillbirth cases and over 2,000 pregnant controls. And when we looked at this, we found, it's highlighted in the red here, that the odds of a late stillbirth were 2.6 times higher if women had reported they'd gone to sleep on their back. And just as an aside, what we're learning now is that the position that you go to sleep in when you go to sleep appears to be the predominant position that you're in for the night, even though people change positions, obviously, but it tends to be the most predominant position. So why is that? Well, if you think about, a pregnant uterus and you're lying on your back on like the left-hand side here, you can see that these blood vessels, the aorta and the vena cava here, are being squished, right? So that means your uterine perfusion is going to be impaired because you've got reduction in venous return, reduction in ejection fraction, reduction in cardiac output. And there is something called maternal supine hypotensive syndrome, right? Now, if you think about flipping somebody over onto their side, it's typically their left side. You see how those vessels sort of open up again, and then you can get that perfusion through to the placenta. So this is not, it's not unknown. I mean, we know that this happens, but I think people just don't think about it in terms of sleep. So if you work in labor and delivery, you would see this a fair amount where women are being monitored when they're in labor. You can see on this figure, the top half is the baby's heart rate. So here, the baby's heart rate has dropped. This is sort of during labor, and then the nursing staff have quickly gone in, flipped mom to her left-hand side, and baby's heart rates come back up. So it's kind of a known thing in the labor and delivery units, but I just think people haven't connected that and thought about, wait a minute, what happens if somebody is lying on their back, for hours every night in the third trimester and nobody's there to sort of, flip them over? And so what is the baby doing? What is the fetus doing when the mother is in different sleep positions? Well, the New Zealand group have actually looked into this. And what they've done is looked at the different sleep stages of a fetus, because you can measure that. And when the mother is in different positions. So here, what they found was in the supine position, when the mother was supine, the fetal heart rate variability reduced, and the fetal behavior changed from very active behavior to a quiescence. And the quiescence is a low oxygen consuming state. So that baby's just become kind of quiet, maybe consuming, so it doesn't consume so much oxygen. And so, this is known like in the presence of a stressor, right? If that's hypoxia or maybe, the uteroplacental perfusion problems, a shift to this low oxygen consuming state would actually be a protective thing for the fetus to do, right? And so the results of this study suggest that maybe maternal supine sleep position is not good for fetal well-being, and in certain compromised pregnancies, which we don't really know what those are, but that might be a sufficient enough stressor to contribute to fetal demise. And I'm sure it's not a single thing. I'm sure it's, multiple things all kind of coming together, but then have a mother sleeping in the supine position could be a bad thing for the fetus. So the same group in New Zealand also looked at functional MRI of healthy pregnant women, and they looked at the comparison with blood flow and oxygen transfer when the woman was in the left position compared to when she was in the supine position. And what they found was that when she was in the supine position, there was a drop in about 11% in fetal umbilical venous blood flow and a drop in about 6% of oxygen delivery to the fetus. So again, if this is a very healthy pregnancy, maybe this is okay and the fetus does okay. But if it's a compromise, maybe if the fetus is growth restricted or there's something else going on, this could be something to tip the scales in the wrong direction, if you like. So again, lots of activity in this area to find out, what's the highest risk fetus that this could be impacting.
Can I ask one question? Can I ask
go
one
ahead?
question?
Yeah.
Many. I'm writing so many notes. This is amazing. One question about the maternal supine position. What you just presented wasn't just fetal impacts from the mother's sleep disorder breathing, but it's just positional.
Position. This is just position.
Yeah. That's positional, just from the aorta vena cava being compressed, but not related to mother's breathing. Okay.
Correct. You raise a really good point, though, is what happens if somebody has sleep apnea and also sleeps on their back, right? That we don't know. In surveys, so just asking, questionnaires about how you sleep. Do you have sleep apnea? Do you snore? Do you sleep on your back? We haven't found anything, any strong signal there. But honestly, I feel like we need to do these kinds of studies, like the MRI, but maybe repeat this study, but with somebody who has sleep apnea, because these women, I don't believe I don't actually think that they tested these women for sleep apnea.
I also wonder, sometimes when you have sleep apnea or any form of sleep disorder breathing, you can't sleep on your back because you feel it's harder to breathe. So in some ways that could be protective from this positional problem, because you might either need to lay on your side to breathe, or I don't know, like tipping the head or upper body up, but that still would cause that compression of the aorta vena cava. So just really interesting information here.
Yeah, no, that's a great point. And I think, I'd love to do those studies, because it could be, right? We just don't know. And, when we did the studies of position, before, I was surprised at how many people did sleep on their back in their third trimester, because I wouldn't have thought that was very comfortable, even if you didn't have sleep apnea. So yeah, I would love to do those studies. They're so important. That's a great
so
question.
interesting. And they have those great pillows. I remember it will look like a huge worm, like a 6-foot body pillow that encourages you to sleep on your side. And then it supports the neck, and then it supports the belly, and then it goes between the legs to support your knees. And that's a really great sort of strategy, I would think, for pregnant women to help cue them to sleep on their side.
Yes.
And you're also
yes,
suggesting the left side is better than the right as well.
Yes, although I mean, there's data coming out now that maybe the actual side doesn't matter, but historically it's always been the left. But I think, you know, there are groups, you know, interested in the position, like you said, with the pillow, and, you know, can that be helpful? Can we recommend that to women for this, you know, for the reduction in stillbirth? So those studies are ongoing. So yeah, you raise a great point. Very exciting times to see if we can, you know, really move the needle on stillbirth reduction. Okay, so like I said before, these were maternal kind of self-report of sleep position, right? And there's no real data on objective measures of sleep position across pregnancy. There was actually one study came out looking at objective sleep position and showed no association with outcomes. However, that was in the middle of pregnancy. It wasn't to the end, where we think is the highest risk in the third trimester. It was more in the second. So, you know, we'd like to see that data coming out of the third trimester, when the uterus is really big and heavy. And so this is an area that I'm really interested in, because, you know, we just don't have the data. And so going back to the study where we did home sleep testing in early pregnancy, and we went back to the same women later in pregnancy, later in the third trimester. So we did that with sleep position, and, you know, again, we were shocked, right? We were shocked that women actually slept on their back as much as they did. But, you know, it was a third of women in early pregnancy, and even more in late pregnancy. I couldn't really get my head around that. But, you know, the data are the data, right? It's not what we thought. But not only that, you know, the amount of time that people spent supine wasn't insignificant. I mean, you know, in early pregnancy, it was about 17% of the night. But in late pregnancy, it was almost a quarter of the night. So, you know, we've got another study where we're measuring this as well, and we haven't finished that. So I'd be really interested to see if the data that we're collecting at the moment mirrors this, because this was a surprise to me. That's what I can tell you. But in terms of, you know, sleep being almost like a predictor of poor outcomes, whether that be maternal or fetal outcomes, I mean, it's biologically plausible. And I know this is a really busy slide, but just to kind of show you that, you know, there are lots of different sleep disturbances, right? And we've really focused on the ones on the right-hand side, like the OSA and the sleep disorder breathing and a bit of supine. But when you think about the mechanisms, you know, the mechanisms are things like, you know, intermittent hypoxia. So the oxygen drops, we get oxidative stress, endothelial dysfunction, inflammation, you know, activation of your sympathetic nervous system, you get sleep fragmentation. If you're talking about your circadian rhythms, we get desynchronization of circadian patterns, which can change your hormones, right? So there's this biological mechanisms by which all of the things that we've talked about make sense from a physiological standpoint, and how, you know, things like your inflammation, your intermittent hypoxia can lead to increase in blood pressure, can lead to problems with the placental perfusion and the blood flow reaching the fetus. And all of those things, you know, play into ultimately ending up with a diagnosis of hypertension, diabetes, or the baby being preterm or growth restricted, or even you know, stillborn. So all of these things that we've talked about have a biological plausibility behind them, which is really important, right? They're not just spurious findings. There's a mechanism why all of these things might be happening. And if there's a mechanism, then that tells us, you know, we have ways to intervene and test whether interventions, you know, are working. So that leads me to say, you know, is pregnancy a window to intervene? And I would argue that absolutely it is. And I think this goes back to our earlier discussion, you know, why do we not talk about sleep during pregnancy? And I think people just have so much going on in those, those very brief encounters, right, during a well visit. But we shouldn't be ignoring this, because what we shouldn't do, in my opinion, is say, oh, well, when you've delivered your baby, come back and we'll look at your sleep. Because to me, we could potentially change the trajectory of that newborn's health, potentially, by intervening during pregnancy and not waiting until the baby's born. That's a missed opportunity, in my opinion. So when we think about adverse pregnancy outcomes, right? So all of the adverse pregnancy outcomes listed here, whether that be preterm birth, gestational diabetes, preeclampsia, all of those things, there's data to show that these things are linked with cardiovascular disease later in life. So women who have gestational diabetes, preeclampsia, or adverse pregnancy outcomes like preterm birth, those are known risk factors for cardiovascular disease 10, 20, 30 years later. Doesn't mean to say everybody's going to get them, but they're risk factors, right? So they're well known. And so if we kind of go the step before the pregnancy outcomes and say, wait a minute, sleep plays a role in all of these things, in my mind, that's telling me if we can intervene through sleep to improve these pregnancy outcomes, maybe we are also improving those downstream, much longer term effects of cardiovascular disease on the mother, and actually, maybe on the offspring too, right? So I really, really think, and I really believe that sleep is this window that we should not be ignoring, and we should be assessing and, diagnosing and treating now, and not waiting till after delivery. And so, for example, if you think about a hypertensive pregnancy, so this is what we're looking at here is blood pressure. So systolic on the top picture and diastolic on the bottom. It doesn't matter which one you look at because they're kind of both the same. But what you see here is somebody going to sleep, which is on the far left, and waking up on the far right. So this is the nocturnal period. And really what you see is the blood pressure is trending upwards, right? Typically, we'd see dips in blood pressure during the night, but here it's kind of getting higher and higher. And so this is a pregnant woman with hypertension, blood pressure is going up during the night. If you give her CPAP, right, which is the typical treatment for sleep apnea, look what happens to her blood pressure. Flattens it, okay? So straight away, we potentially have some impact if this woman isn't, getting hypertensive all night, every night. We might have a window there of helping. And so there was a study that came out of the Stanford group a little while ago. This was a very small study, but we were doing a similar study at the same time, so it really caught my attention, is that these were women who were high risk for preeclampsia from the beginning. So going into this particular pregnancy, they knew they were high risk. They enrolled in this study, so very small study. It was something like 9 women in one arm and 7 in the other. So very small, but I think very impactful. And this is systolic and diastolic blood pressure in the 2 graphs. But again, they're basically mirroring each other, so you can just look at one. And so these women were either randomized to standard of care, which is the blue group, or standard of care plus CPAP. So they're basically going to the intervention for sleep apnea and follow them through their pregnancy. And so what happened here is that, nothing really happened till about 30 weeks, right? Till about here. And then you start seeing significant differences in the blood pressures between groups. And so what you see is the blue group, which is the standard of care, their blood pressure is going up because remember, these women are high risk for preeclampsia. But in the CPAP group, the blood pressures are pretty stable. And what's even more interesting about that is that the medications for high blood pressure were going up in the blue group, but they were staying stable or actually tapering down in the red group, right? And yet the red group are the ones with the better blood pressure right now. And so once we got to about 30, 31 weeks, those blood pressures were significantly different, right? And they were much better in the women who'd been given the CPAP during pregnancy. So that was very exciting news. And like I said, we were doing a similar study at the same time where we'd enrolled women with hypertension. We didn't care what their sleep was. They didn't have to be in the study because of sleep apnea. They were in the study because they had hypertension. And we gave them either, it was auto PAP, so auto titrating positive airway pressure, or they didn't didn't have that. They had standard of care. And so we had women who used their positive airway pressure device, and some that didn't, right? Just like in clinical care. And when we looked at their blood pressures, we found that up until about 4 weeks of use, nothing was really different between the women who used the device versus the women who didn't. But once we got to about 4 weeks, those blood pressures again started separating out. And it was the ones that weren't using their positive airway pressure started to go up. And the ones who were using it started to stabilize or maybe even come down. But it took about 4 weeks to, see a difference, but not unlike that other study from the Stanford group, where they also, didn't see anything for a little while. But then what was very interesting to me is that in our blue groups, this is our non-compliant positive airway pressure users, about 2/3 developed worsening blood pressure and ended up with a diagnosis of preeclampsia, despite the fact that they were having antihypertensive medications. And the vast majority of the rest of them had increased dose of medications, even if they didn't ultimately end up with a diagnosis of preeclampsia. And when we looked at our red group, which is our compliant positive airway pressure users, only 27% of them got worse in terms of their blood pressure and ended up with preeclampsia. And the vast majority of the rest of them had stable or even decreased doses of medication. So again, it's like, okay, this is more evidence that positive airway pressure in women with hypertension, in this case, not even underlying sleep apnea, seems to help blood pressure control. So could this be a tool in the obstetrician's toolbox to help blood pressure control? So we've also done a study with positive airway pressure in women with sleep apnea and depression. Remember I said that depression is, common comorbidity of sleep apnea. And what we found was those with typical care, as we went on for 8 weeks, their cortisol levels or their stress hormones were going up, whereas women who were using the positive airway pressure, their cortisol levels were coming down. And not only that, but when they were adherent to the treatment, the positive airway pressure, their depression scores fell over time. So their depression symptoms really improved over time when they were using the positive airway pressure. And that's likely because they were getting their sleep apnea treated. And we know there's a link between sleep apnea and depression. And so they were feeling better in terms of their mood when they had their sleep apnea treated. So what about fetal movements? So this graph is looking at the hours of maternal sleep along the bottom and then the number of fetal movements on the side. And we see in the dark bars, this is a healthy pregnant woman that as the night goes on, you see like an increase in fetal movements across the night. But if you have preeclampsia, which is the gray bars, you see a real reduction in fetal movements, which is pretty typical, right? If you have preeclampsia, a lot of the time you don't feel as many fetal movements. But the white bars show the same women in the gray bars, but with positive airway pressure treatment. You see that the fetal movement has started to come back. It's not back to maybe optimal levels, but it's certainly improved compared to no positive airway pressure. And so, why is that? We don't really know, but we think, because the preeclampsia is linked to the, impaired cardiac output and increased vascular resistance, and therefore the perfusion, through the placenta is not great, that if you can treat with positive airway pressure, you can improve all of that. And maybe that's why the fetuses move more. So going back to what I mentioned earlier about the growth problems and falling across the growth curve, we've done a study where we didn't just take a 32-week ultrasound, but we took multiple ultrasounds in the third trimester. So we had to have at least 3 measures plus the birth centile, and we sort of, joined the dots, if you like, to see who fell across the centiles. We had 54 women who did not have sleep apnea, and we know they didn't have it because we tested them. We had 34 who had sleep apnea and for whatever reason did not want to be treated. And then we had 14 who had positive airway pressure treatment. And when we looked at the fetal growth, what we found was that in the untreated women with sleep apnea, there was 3 times increased odds of fetal growth problems. So that's the falling across the centiles, like in that graph. But you see, it wasn't just from 32 weeks to delivery, it was multiple time points across the gestation. And interestingly, when we looked at the small number of women who had positive airway pressure, we found no differences in the fetal growth trajectories between these ladies and the ones who were controls. right? So again, this is more evidence saying, hey, if they're treated with positive airway pressure, maybe that helps with fetal growth. And this is a real sort of interest area of mine. So in that study, we found that we were able, by using positive airway pressure, we were able to improve the infant birth weight. These are high-risk babies, so they were all smaller than typical, but the ones in the positive airway pressure group were bigger than the ones that didn't use the device, didn't use the treatment. And that's probably because we kept women pregnant for longer, right? So when they were using this positive airway pressure therapy, they stayed pregnant about 2.5 weeks longer, which clearly is significant when you think about, the costs and the burdens of preterm delivery. And then women were telling us that, we could see from their medical records that their blood pressure was controlled well, they were feeling better, and they were actually telling us that they could feel their baby moving more. And that's kind of what preempted our study looking at the fetal heart rate that I presented earlier. So what's the link between the mom and the baby? It's the placenta, right? So who's looking at the placenta? Not enough people, as it happens, but there are a few. So markers of tissue hypoxia, as well as markers of angiogenesis, are more common in women that have OSA compared to controls in their placenta. And we've looked at the fetal placental weight ratio, and we've seen that as the severity of sleep apnea gets more severe, this fetal placental weight ratio goes down. We also notice choreangiosis more in women with sleep apnea compared to control women or women on treatment for sleep apnea. And choreangiosis is an increase in the number of vessels in the chorionic villi, and that's much likely a result of hypoxia because nucleated red blood cells were also elevated, which they get elevated when there's not enough oxygen. So, all of these kind of things are playing into mechanisms. If it's affecting the placenta, it's going to affect, the baby. And what we're looking at now is, can we get some kind of signature? Can we see a marker in the placenta like you can for hypertension or diabetes? Is there some kind of marker maybe that we could look down a microscope one day and say, I think this lady has sleep apnea? I think that would be amazing if we could do that, but we're not there yet. And again, just more work to show that there's more evidence that there's hypoxic stimulus going on in women with sleep apnea, and we can see that in the placenta. And there's a higher frequency of fetal and maternal circulatory disorders in women who have OSA, and again, we can see that in their placental tissue. So let me just present a couple of cases to you. These are very interesting cases and really kind of spurred us to do more of this work. This lady was a 32-year-old Caucasian lady. She had a normal BMI, but she had a really awful obstetric history. She had lost a baby at 20 weeks and another one at 19 weeks because of preeclampsia. She had a premature delivery at 27 weeks with her third baby. The baby ended up in the NICU. And then with her next pregnancy, we were doing our study with the positive airway pressure, and our obstetrician asked if she could be in this study. She technically wasn't eligible because her blood pressure was normal, but we managed to get sort of an exception through our ethics committee to allow her to come onto the trial. So she enrolled on the trial. She did not have sleep apnea, and she adhered to the positive airway pressure. She was amazingly adherent to this treatment. And she did not develop preeclampsia, and she delivered a healthy male baby at almost full term. And this was the first time she'd taken a baby home in her arms. And this made us kind of go, wow, did we have something to do with that? And I'd like to think we did, but obviously it's an N of 1, right? So we can't really say either way. But we went back and looked at her placenta, and interestingly, the placenta from this baby, the fourth baby, was normal except for one tiny little infarct, unlike her previous placenta, which was very, very typical of those changes that you see in preeclampsia. So I'd like to think that was due to the positive airway pressure therapy, but of course I can't prove it unless we kind of have a study on this and we focus on this. But my gut feeling is telling me that we might have had something to do with that.
Well, I feel like I'm sure you did. And here's my question. Although we say this lady did not have sleep apnea or sleep disordered breathing, how many women are misdiagnosed because of upper airway resistance syndrome? So perhaps that was something she had that we were unaware of. Is that possible?
That is possible. Yeah, that is possible. She had, I'm trying to think, this is a while ago, I'm trying to think whether she had an in-lab study or a home sleep study. I think she had a home sleep study.
Mhm. So
So it's
we
very
know,
possible that we could have
yeah,
missed that.
right,
Mhm.
because as Dr. Simmons says, they should be coined HSAT, home sleep apnea study, because that's
Mhm.
all they're picking up on is apnea. And
Mhm.
even in lab studies will miss upper airway resistance
Right.
syndrome in so
Mhm.
many cases, which was something that happened to me. And then I did the sleep study with Dr. Simmons with the pharyngeal esophageal
Mhm.
manometry, which that picked up on the
Yeah.
UARS. And
Yeah.
we know
Absolutely.
the way these sleep labs are scoring, some are still using Rule 1B and only counting an event if
Right.
there's an oxygen drop. So many women with UARS are getting missed.
Right.
So I
Mhm.
just question, perhaps in this particular case, there was an underlying, sleep fragmentations from our upper airway resistance syndrome that might have been missed. But wow, what an amazing
Yeah.
story for that case you just presented.
Yeah, no, you have a great point there. We didn't do any esophageal pressure manometry in pregnant women, and we haven't actually done that. But that does raise another question: is I think we're missing a lot anyway, but I think we're missing even more when you think about the UARS. Yeah, that's a great point. I would love. I mean, this was a long time ago. I'd love to explore that more. But I think trying to get women to have the esophageal pressure manometry might not be
Right.
easy.
Yeah, and I think also just knowing that there are so many signs, like physical, anatomical, structural signs in the mouth when somebody has any form of sleep disorder breathing. It doesn't have to be full-blown
Right.
sleep apnea, right? But even open mouth breathing, snoring, UARS,
Hmm.
we can see oftentimes scalloping on the tongue, narrow
Hmm.
palate, crowded teeth. What the
Yep.
history of orthodontics is that, hey, we might be kind of clued in to a form of sleep disorder breathing without even needing a sleep study. So much
Right.
interesting stuff. But for
Yeah.
this first case you presented, bless that poor mom, and so wonderful that she was able to bring home a baby after going through all
Absolutely.
that. Wow.
Absolutely. Yes, we were. Everybody was really delighted with this outcome. Yeah. And then this second case, this presentation was much more typical of what we saw in the study. So this was a 34-year-old African American lady. She had gestational hypertension. Her BMI was 42. This was her first pregnancy, and she had high blood pressures at enrollment, as you can see there. And so what happened was we would do a sleep study like the night before we'd start them on the positive airway pressure, and then we wouldn't look at the sleep study until afterwards. And so in this case, she had the sleep study, and then the morning after the sleep study, she appeared in triage, and she had a non-reactive fetal heart rate, reduced fetal movement, and severe maternal desaturation. And so the OBGYN plan was to deliver her that day. She was 37 weeks. But we had a very astute fellow or resident on that day, and they noticed that she was in this study. And so they paged us and they said, no, she's in this study. They gave us, the background. And it's like, well, she's your patient, it's your decision. But here's something that we could do. We could actually start positive airway pressure now. This was like 10 o'clock in the morning. We could actually start it now instead of waiting till this evening. And so everybody agreed, her care team agreed that would be a good thing to try. So we did that. And, in the meantime, I went back to look at her sleep study, and she'd had severe, severe, like really severe OSA, 117, per hour. I mean, that's not the highest I've seen actually, but it's one of the highest. But this kind of explained why she would, doze off asleep if you sat on the bed and talked to her. Like it totally made sense, right, from the sort of phenotype that you saw. And so anyway, so she went on the positive airway pressure, and while she was on that, the fetal heart rate became reactive, her maternal sats became normal, and her blood pressures actually came down. I mean, she was still on meds, but the only thing we'd done differently from the week before was to, put her on the PAP, right? But their blood pressures came down. So she was discharged, and she was told by her care team to, use this positive airway pressure machine every time you go to sleep. Even if it's a nap in the middle of the day, use this machine. And she did, and she used it, and she continued her pregnancy for another week, which nobody was expecting, right? And she delivered a healthy baby girl. So we were like super happy. Again, it's like, okay, there's something in this positive airway pressure, right, in this population. So now fast forward 2 years, and she gets pregnant again. So now we know that she has obstructive sleep apnea. And so she was instructed by her clinical team to use her devices. She's out of the research at this point, right? So she's instructed to use a positive airway pressure device, but of course she now has a toddler at home, right? Our initial index baby is now a toddler. She has her hands full, and the positive airway pressure device is basically in a cupboard, and she doesn't use it. And then at 28 weeks, she comes to triage. She has reduced fetal movements, and the baby was stillborn. Now, I can't tell you that if she had used it, that the outcome might have been different. But it's an N of 1 again. But I can't help thinking that if we'd been able to, have her on optimal therapy, that maybe the outcome could have been a little different. So this was kind of really sad for us to learn. Like I said, she wasn't in the study anymore, but her care team did come and tell us what happened. So that was really sad. So that's interventions for, sleep apnea or potentially even high blood pressure, I guess. But what about interventions for position? So we do have a couple of those studies. So we did a sleep position intervention called the Prenabelt study. And we did this in Ghana, actually, because Ghana have a really high perinatal mortality rate. And the Prenabelt is essentially built off the tennis ball technique. So the tennis ball techniques, like where you put a tennis ball, in the back of your shirt and nobody lies on their back because it's uncomfortable. So you can see the belt in this top corner. This is at the back. So we have these kind of more hardened balls that they're not tennis balls, but they're, more harder balls. That we also have a foam one. So that's they call it the sham control. So if women lie on their back with the foam ones, they can lie on their back. The foam ones just squash down, right? And so we had 200. Well, we wanted 200 women. I don't think we quite got 200 women, but the goal was to get 200 women. We got about 160, 170, I think, randomized them to the sham or the actual Prenabelt device. And what we found was that in the actual device, we were able, the women ended up with slightly bigger babies, right? Not significantly different, but certainly trending that way. And given that we didn't get our full 200 to be fully powered, I was kind of, I was quite happy with these results, and that the birth centile of the babies was bigger in the women who had had the active intervention. We were also able to reduce their supine sleep by about 30 minutes and reduce the proportion of time they spent on their back during the night, and also reduce the proportion of babies born small for gestational age. So again, this was promising. I mean, it wasn't statistically significant, but it was certainly promising in the right direction, that maybe an intervention for supine sleep could be promising. And again, this is outside of sleep apnea, but the question remains, what happens if women have both sleep apnea and they sleep on their back, right? We've done a study also in Australia where we've looked at, the same intervention, the Prenabelt. We've looked at how much time women have spent supine, and we've also looked at those fetal heart rate decelerations. And what we found is that with this belt, we do decrease the time spent supine, and we also decrease the number of fetal heart rate deceleration. So again, positive findings. A small study, but positive findings. And then we have a larger study ongoing at the moment. We're about halfway, I want to say, through this study. And it's really powered to determine if supine sleep is related to shorter gestational length and reduced birth weight. So it's basically a little vibrationary device. It connects to an app on a phone. Women are either randomized to just observation, so the device just tracks whatever they happen to be doing in terms of position at night. And then there's another arm of the study which has a vibration alert. So if the device senses that women are sleeping on their back, it'll give sort of a vibration that women sort of will subconsciously turn off their back when the vibration is going on. And we hope that, by doing this, we can improve pregnancy outcomes. But like I said, we don't have full data yet. But what I can tell you is that what we've been able to do with the vibrationary device is we've been able to reduce supine sleep from about an hour down to less than 15 minutes. So we've had almost an 80% reduction in supine sleep time. So will that translate to, people staying pregnant for longer, therefore having, higher birth weight babies? I don't know, but I'm hopeful. So watch this space. And so with that, I'm going to circle back to my initial slide talking about the burden of sleep disorders on pregnancy outcomes. Like I said, this is financial burden, but there's also the whole psychological and traumatic burden for many of these outcomes. And I would argue that all of these billions of dollars here, we could actually improve that, I think, pretty significantly if we can identify and intervene on some of these key sleep problems during pregnancy, and being able to reduce these really important and common pregnancy outcomes. And so with that, I will summarize and say that maternal sleep is a really significant contributor to both maternal health and fetal health, and most likely long-term child health, especially when you think about things like gestational hypertension, preeclampsia, gestational diabetes, fetal growth problems, and also stillbirth. And I really do believe that interventions during pregnancy to optimize maternal sleep could offer significant benefits, to moms and babies, and benefits to them, but also benefits to the health system, right? So I think this is an area that we really need to focus on. So thank you very much.
Wow. I need to breathe. You need to breathe. I can't. That was so amazing, so thorough. I literally have the chills. I cannot believe all of that information. How fascinating, how important is it that we all understand about pregnancy and the impacts of sleep on pregnancy, on maternal and fetal outcomes, not just talking about airway, but anything that impacts sleep and sleep quality has a potential to impact that developing fetus, the quality of life of that baby that will be born and grow into a child and an adult. You talked about sleep disordered breathing, snoring, positional impacts, timing of sleep, circadian rhythms, all of these things that can impact the growth and development of that fetus, which is so interesting. Some of my big takeaways, like we always say, just because something is common does not mean it's normal. It might be common that women might snore during pregnancy, right? Or that gestational diabetes might have higher percentages. And as that mother develops further in the pregnancy, okay, that might be somewhat common. This is not necessarily normal. Good breathing is natural medication. Good breathing is natural blood pressure medication. You're showing when these pregnant women are put on CPAP, blood pressure can be controlled, fetal movements can increase, fetal growth can increase. This is breathing. This is airway. I have so many notes and so many questions. I know we probably have just a little bit of time, so I got to consolidate all my thoughts. But one thing that also came to my mind was Dr. Ghazal has stated before that sleep disordered breathing is a disorder of systemic inflammation that likely began before birth, right? Before birth. I always present on Dr. Guilleminault's studies about fetal development, and he talks about that last trimester in utero, the fetus is like an athlete, and they're training reflexes, they're training breathing, not for oxygen, but for training. They're swallowing amniotic fluid, not for nutrition, because they're getting nutrition from the placenta, but it's all training. So premature infants are at a risk for sleep disordered breathing and all these other issues as well. So for the mother to be able to hold on to that baby full term is really important for so many different reasons and different factors. And I just wonder, one question is, if women, we think they should be put on CPAP, these higher risk women, or we see red flags or signs or symptoms that they're at risk, what do we do if the female can't tolerate the CPAP, or the CPAP might actually be impacting sleep quality because it's uncomfortable? Do you have any suggestions for that?
So I think that's another great question. People don't typically like CPAP, right? And what we've heard from the women in these studies is that, often they have another child at home, right? Often a toddler, and the toddler will sometimes come into their bed at night and they're frightened. They're frightened by seeing mommy in a space mask, right? Because that's what it looks like. And so that is a concern. That's one of the barriers I think that women have. They don't want to have that on their face. Many women, I know I've shown you some extremes here, but many women will have more mild sleep apnea. And so maybe, oral appliances are a good option. That could be a good option. In Michigan, actually, we have developed another treatment, a nasopharyngeal oropharyngeal airway, which is in trials right now. We're not trialing it in the pregnant population yet, but that's certainly on the list to do it. And so that is something that doesn't need electricity. It doesn't need to be plugged in anywhere. It's very easy to travel with. So I'm kind of excited to see where that goes, because I definitely would like to trial that in this population. It's a nasopharyngeal oropharyngeal airway. So it's almost like a very fancy, well-developed, comfortable straw in a way, just as ease of a visual that clips onto the nose. And we have a trial in children that we are getting close to finishing now. But I'd like to trial that in the pregnant population as well, because of all the problems with tolerating CPAP.
Okay, and does it blow positive airway pressure?
No, it's just a stent that holds the airway open. It's really simple.
And does it go into the nose or just? Oh,
Yep.
Okay, interesting. Okay,
Yep.
so stenting the airway open, physically, mechanically,
Yes.
without.
Yes.
Oh, interesting.
Yes.
Okay. Wow, really interesting. And I did have a patient who was she was probably referred for TMJ reasons, and then most of those are airway patients. And she was, I believe, in her like early 30s, and she did great with myofunctional therapy and the treatment we were doing. And then she got pregnant, and we knew this is high risk because I knew she had symptoms of UARS and sleep disorder breathing. So we were able to refer her for a sleep study and to an oral. She didn't want CPAP, but she got on oral appliance, and then she delivered a healthy baby. But that baby had tongue tie and similar issues she had, so we ended up referring the baby for help as well. So it's just interesting when we can identify early, we can impact generations of family members. Interesting too that you said sometimes the first pregnancy can be a shock to the system, where maybe a mother who did not snore prior to getting pregnant and then began snoring. So pregnancy-induced snoring, those are the ones that have more significant blood pressure issues. And you described that maybe that's shocking to the body, that pregnancy and all of a sudden triggering worsened sleep disorder breathing, which is interesting for me because I had a miscarriage as my first pregnancy. And I think miscarriage is somewhat common, but is that also a sign of issues that are being missed? And my second pregnancy was the one where I had the gestational diabetes and all those, issues. And I felt like it was a shock to my body. But my next pregnancy, so my second son, I didn't have diabetes. And they said, you are going to have, I believe it was like 80% chance of having diabetes. Again, we're going to test you so many times. And I had to drink that gross sugary drink for the blood glucose test. And nope, didn't have diabetes, which was pretty surprising that it didn't happen the second pregnancy. And once you get diagnosed with gestational diabetes, they say you're at a 50% increased risk of developing diabetes as you get older. And so far, my blood sugar, my A1C has been really good, possibly because I've treated airway issues. But it brings me back to what you described about like that first pregnancy, and can be maybe a shock to the body, and symptoms can be worse when you develop the issue maybe more strongly, the breathing issue, when you become pregnant versus maybe the chronic aspect of it. Because you said the blood pressure went extra high on those women. That was just an interesting thought. What about also the males who have sleep disorder breathing? I know I've heard Dr. Kevin Boyd say, let's not only blame the females, but what about the males? And is there an impact on sperm and things like that as well? So do you know anything about that? Are there any studies on that?
There are studies, actually, not many. I think sometimes it's harder to get the men into some of these studies. But yes, we know that sleep apnea is linked with erectile dysfunction. We know it's linked with, reduced quality sperm. That those literatures exist. I mean, so it's not just the woman. You're absolutely right. It's, but I think this is an area that there's really not enough research in. There needs to be more in men. There needs to be more in couples. We've done a little bit of research with couples, undergoing reproductive endocrinology. assessments. We found it actually really hard to get more of the male in the study, for various reasons. I just think they were less open to being in a research study about, their sexual health than the women were.
Right. Yeah, that makes sense. I can see that that could potentially be a problem to study if, they're not interested in exposing that type of information.
Right.
But for people who are having difficulty getting pregnant or
Mm-hmm.
multiple miscarriages, it's something to maybe consider. It's not just in the
Right.
female, but it could be something with the male and something with sleep
Right.
and breathing. Also
Right.
back to CPAP and depression. I wonder, women who suffer from postpartum depression, are those typically females who have sleep disorder breathing, and could CPAP help with postpartum depression as well? Is there any research you're aware of on that?
I mean, very little, to be honest. CPAP, I will tell you, it's hard in pregnancy. It's even harder in the postpartum period, just because there's so much other stuff going on. We definitely, in that study, we definitely had more of a drop off, in participation after the babies had been delivered. But poor sleep quality in pregnancy is a well-known risk factor, whether it's related to insomnia, whether it's related to sleep apnea, but it's known to be really tightly entwined with depressive symptoms. So I think one of the best things that women can do, postpartum is, talk about their sleep. If they're concerned about their sleep, bring that up, because sleep and mood are so tightly entwined. We shouldn't really be talking about one without the other.
That's definitely true. And a couple questions for you as we wrap up. Just your thoughts. How should obstetricians screen for sleep breathing issues? How do you think? And I assume you would say that should definitely be part of routine care. So, what do you recommend should be done?
Right. Well, there are standard screening tools out there, but they were developed in, one of the risk factors for sleep apnea is male and over 50, right? In some of the standard screening tools, and that doesn't really apply in this population. So I don't think the standard screening tools are great in this group of patients, and that's been shown, right? So it's been shown that they really don't work very well, and people have tried to develop pregnancy specific ones. What we found works the best, honestly, the most highest risk women are if you have hypertension and you snore frequently. Those are the women at the highest risk. I might even go as far as to say if you had a growth restricted baby and you have frequent snoring or symptoms of sleep apnea. And I think the problem is, if you refer everybody who snores when they're pregnant to a sleep lab, it's going to be overwhelming. So I think you have to look for the highest risk woman. And I think that's the hypertensive woman with frequent snoring.
Okay. Okay, that makes sense. And then if this is identified, sleep disorder breathing issues are identified during pregnancy, we talked about some of the interventions, but is it always CPAP or maybe oral appliance, or would we say position, or kind of how would you sum up what would be the best recommendations? And what if it's identified at a really early stage of pregnancy, or a woman goes into pregnancy knowing they snore? What's the next best step?
Right. Well, I think all of the above, actually. So it might depend on, stratification, right? So if it's, really bad symptoms and, they have access to referral to a sleep lab, that would be the best way to go potentially. But then again, there are caveats with wait lists and all sorts of things. That's a big problem, right? Maybe you have to wait 3 months to get in, and, pregnancy doesn't wait. So so maybe a home sleep test, that we know there's caveats with home sleep testing, but maybe that's a quick way of, getting some objective data, right? If it's mild sleep apnea, maybe oral appliance works, maybe position works. We know that many women do have more mild side of sleep apnea compared to, the severe. So, positional therapy and oral appliance, I think, have a role.
And I believe Dr. Simmons is doing some research or studies on using a sleep image type ring that he
Yes.
uses for all of his patients, right?
Yes.
Nightly monitoring of sleep breathing, which could be a fascinating, when that research comes out, a fascinating addition to simply wearing a special ring device that can
Yes.
detect a cardiopulmonary coupling that could detect these issues, track, monitor. So that could be a whole different modern way to identify and
Absolutely.
treat this issue. So
Absolutely.
what gives you hope to where this field is heading? What are your hopes or thoughts?
Oh my gosh, I think my first hope would be that we can routinely be asking about sleep in prenatal visits. And not just in the first one, but keep asking about it because we have the capacity to do it, right? A lot of hospitals are using very similar electronic medical records where, a medical assistant can ask the question before the obstetrician comes in. It doesn't take too long. I think the challenge is what to do with that information. If an obstetrician isn't sleep trained or doesn't know a lot about sleep, I think it's a little bit like, oh, now what? So I think that's where we've got to bridge the gap. So I think we can get people to ask the questions. It's what do we do when we have the answers, right? That's more of the challenge. And even in big medical centers like ours here at the University of Michigan, yes, we have a lot of sleep beds every night, but we still have wait lists. And wait lists is a problem in a pregnant population. We do have ways of getting around that. But even if you live somewhere that doesn't have good access to a sleep lab, maybe there's no sleep doctor where you live. I mean, that, again, that's another challenge. So we have lots of built-in challenges, but I think at the very least we should be asking the question, because it's important to know and to be able to get women some kind of intervention, even if it's saying, if you have these symptoms, please don't sleep on your back, please use the positional therapy. There are things that we can do to minimize it, even if we can't have access to a sleep physician.
That's true. And even use nasal saline and blow your nose, and even those types of impacts that could help even slightly with better breathing, or don't eat close to bed because that could trigger that snoring reflux that could make the airway even worse. So I think that's true. There are so many little changes that could have a
Right.
positive impact, even if we're not hitting the nail on the target
Right.
exactly, because we might not be able to do everything. But it's also a really good valid point that you're saying. We can then identify these things, but if that doctor doesn't know what to do next, that's a big problem. And I just did a big lecture for an orthodontic society where I live, and they started referring patients to me and started identifying. They started seeing those red flags in some of their patients, which is great. But then I realized, oh no, they don't know how to treat them with an airway minded focus necessarily. So that's the next step. Is we can identify, but we also need to know what to do and how
What
to
to do.
treat it appropriately, which is the next an important hurdle. So really one of the biggest takeaway messages from this amazing presentation opportunity I had to speak with you today is by intervening early during pregnancy, we can change the trajectory of baby's health by intervening before birth. And there's so many known risk factors, and we could positively impact the life and the well-being of the mother and that offspring. And I really think this conversation highlights how critical sleep and breathing are during pregnancy. Like we said, not just for maternal health, but for fetal development and that long-term outcome of the baby and the mother as well. Like you
Right.
described, certain issues can persist after pregnancy
Right.
due to weight gain and other factors. So it's just so amazing. So I really want to thank you for all of your research, how you're bringing awareness and highlighting this area that historically has been overlooked. And I think we're now starting to see, as we're recognizing the prolific nature of airway issues and
Yeah.
health and sleep quality. And I just know anybody who is listening to this is going to walk away differently, thinking about airway health and sleep disorder breathing and prenatal care. We got to get this podcast out to every OBGYN, every nurse. I want this to go viral. I want this to be shared. People need to know and understand this information. And Dr. O'Brien, thank you so much for spending nearly 2 hours with us today. I really, really appreciate all of your time, research, and information. I can't thank you enough. Thank you
Oh,
so much.
absolutely. It's my pleasure. It's my pleasure. If we can, help one woman, it's worth it in my opinion. It's such an important and overlooked topic. So thank you for allowing me to talk about it.
It's so true. In your research, when you're helping one person, you're really helping two because you're helping the mom and the baby. So you got double credit for that. Thank you, Dr. O'Brien. I hope you have a wonderful rest of your day and a wonderful weekend. Thank you again.
Thank you. You too. Thank you.
Thank you so much for joining this episode of Airway Answers. I'm hoping some of your Airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.